So this was a very long chapter, but let me summarize the most important points that I brought in this lecture. First of all, we're using several imaging windows: the peristernal window, the apical window, the subcostal, right peristernal, and suprasternal window. We perform imaging from the peristernal, the apical, and subcostal view in all patients. The other two windows we only use for specific situations. When it comes to the peristernal views, we've got the peristernal long axis, short axis at the base, at the level of the mitral valve, at the level of the papillary muscle, and at the level of the mitral valve. In addition, we can use a long peristernal axis to image the right ventricle and the right atrium as well. When it comes to the apical views, we have the 4-chamber view as our standard view. From there, we rotate towards the 2-chamber view, the apical long axis view, and we can tilt so that we also acquire a 5-chamber view where we are visualizing the aortic valve and the LVOT. Don't forget that we have atypical views as well, such as the coronary sinus view, the slanted views where we are looking more at the right ventricle, and the slanted view where we are looking at the lateral wall of the left ventricle, not shown in this graphic, and also a view where we rotate a little bit so that we see the LVOT again and different portions of the lateral wall. When it comes to the subcostal view, we're using a 4-chamber view. We can rotate around this view to also get short axis views, for example, at the level of the ventricle, but also at the level of the aortic valve. This view is ideal to look at the pulmonary artery. And then finally, the subcostal view is very important to image the IVC. The last view that I want to show you here in this summary is the suprasternal view. Here we are looking at the ascending aorta, the aortic arch, and the descending aorta. Ideal view to quantify the size of the aorta, of the aortic arch, and also to look at aortic regurgitation and coarctation. When it comes to M mode, don't forget you should follow the standard protocol. It's important that you can measure here. It has a very high time resolution, so the M mode is certainly something that is important. Don't forget that we can also use the M mode in other situations, for example, to measure right ventricular function with the help of the so-called TAPSE. And finally, when we talk about Doppler, we have spectral Doppler with pulse wave and continuous wave Doppler. We use pulse wave Doppler for the lower velocities, but here we know exactly where we are in the heart. With the continuous wave Doppler, we use it for higher velocities, for example, aortic stenosis. If you use Doppler, that is true for both spectral and color Doppler, adhere to the standard protocol, use it freely, however, and be creative to visualize the jets. Don't forget that if you want to get a very good color Doppler quality, you have to optimize the 2D image first. And finally, consider the direction of flow when you produce the image planes so that you get the best quality of your pulse wave Doppler as well and your color Doppler. So now that you know how to image, it's time to look how we can actually quantify the size of the heart. This will be the topic of the next chapter.